Hi, everybody. Thanks for coming. As you said, I've been working, doing ethnography, using ethnographic methods since about 1984. I graduated from the University of Washington School of Architecture, and I've always been sort of a humanist. So my idea of doing architecture was to understand who was going to actually be using the building. Start out by trying to understand what the business problem was, which is a commercial piece of architecture. And it's been very successful. So when I went back to graduate school 15 years later at the Institute of Design, which really focuses on this kind of research, I just honed my skills. I was able to find out even more methods to use to uncover unmet needs and to understand a complex problem. Just to give you a couple of examples from architecture, because probably a lot of you are wondering, like, everybody asks me, how do you architect become a direct strategist? I work primarily in the commercial realm, and a couple of my clients you may have heard of. One of them was Cinnabon, Cinnamon Roll Shop. People remember those within the malls. They were trying to come up with a really engaging experience, especially to get kids into eating big, huge, calorie-laden cinnamon rolls. And so we did research on what do kids like to do at the mall? How do they behave? You know, what do their parents let them do? Guerrilla research, meaning that you just go out to the mall and walk around and just listen to attention what's going on. I also was the designer for Starbucks. 17th to about 284th store before I finally had a coffee bar and quit. And the way that I actually got that project was to go out to the existing stores and do ethnography and come back to Harshville and explain to them how the stores could be more efficient, less likely to burn people, and encourage you to buy all kinds of posters that you don't really need. So that formula came out of ethnography. And the same, I could say, for there's a cancer research center here called the Cancer Research Center. In 1989, they had successfully done a number of bone marrow transplants, but they needed to be able to do more than one at a time. So they needed a suite of bone marrow transplant rooms arranged with the legs of very highly specialized medical teams. And they needed somebody to help them design that. So I used ethnography to understand what was involved in bone marrow transplant and also to understand what was on the hospital. And put those two together and came up with a plan. And now, of course, bone marrow transplant is very common. So that's a little bit of how you can use this in architecture. What I'm going to talk about today, though, is how we use this in complex problem solving within the UX realm. And so to get started on that, I'm going to talk about what a complex problem is. Sometimes it's called a wicked problem, but I'm going to leave it at complex because wicked can be wicked. And then talk about some of the ethnography or ethnographic methods that you can use. I'm going to go through a case study just talking about the kinds of research we did that mapped the methods to solve a problem in very specific healthcare problems. And I'm currently still working on this project. So it was a big, big problem. And the process of solving it has been over 3 years long. So it's, I think, fairly interesting. And then ideation. What comes out of all this ethnographic research? What do you do with it? How do you communicate what you've learned about a complex problem to the people who need to understand it in order to give you what it is that you need to move forward? Does that sound good to everybody? Okay. So, a complex problem. Sometimes these problems defy definition. You ask people what it is and they can't even describe it to you. It many, many times has a lot of stakeholders. And when I say stakeholders, what I mean is it could be across departments, it could be across industries, it probably has a lot of people who are passionate about it, and they all agree on some of the solutions or approaches, but not all. And we spend a lot of time just sort of spinning in place. The issue is constantly changing. And you'll understand that when I talk about this healthcare space that I've been working in. And it's usually an area that is so complex that the information about it isn't something you can do a simple search on the web to solve. It's either imperfect information, just spotty. Can you hear me better now? Sorry. Okay, now I sound really loud. An imperfect or incomplete information, and then competing values. This is really important, that people who are attacking this problem are coming at it with different points of view, different value systems, different needs, different fears or FUD, uncertainty and doubt, fear, uncertainty, doubt, and different levels of interest. So when you look at these problems, they're not something you can sit around a conference table with 8 people and discuss and come up with a solution. What you really need to do is go out into the place where this problem is occurring and understand it at a deeper level. This is my this is my diagram of complex problems and solutions, my scribble. Every complex problem I see as a triggering event. Somebody says, you know, Houston, we have a problem. The rocket won't launch. We can't capture XYZ in the operating room. Something has happened. Starbucks wanted to sell $4 cups of coffee to people in Des Moines, Iowa who pay 50 cents for them. That's a triggering event. There is a deep need to understand the context of how this problem is occurring, who's involved in the problem, and then to do the creative part of around ideating, coming up with lots of different ideas, collaborating with people that are in the problem and people that are outside of the problem to try to understand what you might be able to do about it. Then you can say, this is the business need, and here's the strategy, and then move forward into solution. Now, what generally happens, especially with my clients, and I've heard through the conference that this is common amongst all of us, clients don't want to spend this time up front. The big bubble up front, it just feels too big. It feels too risky. It feels too expensive. They don't see the risk on the other end of like missing the problem altogether. So the best thing to do is to, well, I have a quote down there from one of my clients, don't do that early fooling around stuff. Why can't we just start with phase 3? So, the idea is, we think we have enough information. We have a whole bunch of people ready to code. So we need you to just get started right now. Do your best. You're a smart person. Come on, you can solve problems in healthcare. You've been in a hospital, emergency room. You should be able to figure this out. It doesn't work that way. And I believe there's many reports about the failure rate of software. Is something, the perceived, I think it's the perceived failure rate is something around 75%, which is just ridiculous. Think of all the money that's being spent on failing, sometimes spending years failing, and not solving a problem at all. So I've been fairly successful getting clients to do this. And I try to be somewhat stealth about it. I don't describe all that I'm doing because it overwhelms them. In the current project that I'm working on, I said I needed to talk to at least 3 to 5 sales reps in the medical space, and I needed to observe for at least a day each a hospital. And they said, oh, that sounds easy. I've been working on this project for 3 months. So what sounds simple, once it's funded, can turn into a fairly robust project. And I think that's the key to actually getting them to do the bubble at the beginning. So what are these methods that are used in ethnography? Well, first of all, ethnography is a social science methodology. It's not a UX methodology. It's not even a product development methodology. It's social science. It comes out of anthropology and social and cultural anthropology. It represents the insider's point of view. So my opinion in ethnography does not matter. I am simply an observer. The insider, the person who is involved in the problem, is actually who I need to get to understand. And you hear
empathy. Developing empathy is important, but really I need understanding to solve the problem. It involves personal experiences and participation. So I'm not observing passively. I'm in the situation. I was in an OR on Friday last week observing a spinal surgery for 3.5 hours. I was in scrubs. I had a mask on. I saw the blood and everything that was going on. I was participating at some level in that surgery. It's an intensive study, and it should be very targeted on a particular problem that you're trying to solve. So you don't boil the ocean with this. In fact, it's the opposite. You gather the right kind of information, and you can really narrow down to a very finite set of ideas that will lead to a very specific solution. So this is actually a way of gathering and then, like that diagram I showed you, narrowing it down to a specific solution. And then it employs a number of data collection methodologies. And I've got the 3 listed there, but I'll show you how I think about it. I think about research as having 4 different components: inquire, dialogue, observe, and participate. Inquire and dialogue are both about what people say. Inquiry is I ask you a question in a survey and you answer it. Dialogue is we have a conversation, you tell me a story. Observe and participate is more about what people do. And observation can be a number of different things. I've got a list of them there. And participating is really like getting right into the problem and role-playing or facilitating some sort of participatory design or something like that. Ethnography primarily belongs over in the observe bucket, although there's certain elements of it that could also live in dialogue. So I'm really going to be talking about both of those. So what are these methods? Ooh, I guess I forgot to write the problem down. Well, I'll tell you what the problem was. So I'm going to go through a little bit of a case study. The company that I have been working for is a supply chain management company in healthcare. They currently manage 70 to 80% of all healthcare spend on materials, medical surgical materials, which is huge. I mean, imagine owning 70 to 80% of the market. They process all of the purchase orders and invoices from every hospital in the United States and match them up with the providers of those, so the materials providers, McKinsey, the GMOs, all the different organizations that are involved in this process. They match those up so they get paid. It's very simple. It's called EDI, electronic data exchange, electronic interchange. Thank you. The area of business, and then they have these ancillary products that do contracts and catalogs and I don't know. There's 16 different products. Lots of products, all supply chain management, all hospital providers and supplier, both. And they were just acquired by a big venture capital firm on Monday, so I think they're going to be growing. Anyhow, this company had one huge gap in that healthcare spend, and that was implants and devices. There's been no company out there in this healthcare space that has been able to figure out how to manage implants and devices in a electronic way. And the reason for this is the supply chain is backwards. Normally, a hospital will place an order with a company, a manufacturer, and they'll get that order shipped. They'll receive it. They put it where it needs to go. They use it, and they pay the invoice. Implants and devices are completely different. They're so expensive. And what I'm talking about is knees, hips, pacemakers, spinal implants, maxillofacial, wrists, small joints, elbows, trauma, all the little metal bits and plastic bits that they put into you to hold your body together. Those implants, a screw can be $1,000. Just a little titanium screw is $1,000. A spinal cage is $5,000. A new knee is $7,000. So these things are really expensive, and every one of you would need a different size, and every one of you would need a different brand because you're either an athlete or you're not. You're either petite or you're not. You're you've got a medical condition or you don't. And so they cannot stock these things. They can't bring them into the hospital and then sell them to you in the operating room. So the manufacturers bring them into the operating room, and they actually sell the products to the surgeon during the surgery. Does that scare anybody? Raise your hand if you're scared. Okay, scares me. So there's actually a sales rep in there whose job it is to sell, and he's on commission. And he's trying to figure out what was put in the patient so he gets paid. There's a surgeon in there whose job it is to save this patient and give him a brand new knee or a hip or fix their spinal problems or whatever it might be. And they're really concerned with clinical efficacy, but they also like going to the parties and the boondoggles of this particular company that's in there with their products. And so, and they're buddies, they play golf together and they have opinions about each other's girlfriends. And so that kind of thing is going on in the operating room. Then you have the nurses who are responsible for recording all this stuff. You have something called a scrub tech, which is generally also an RN, who's on the sterile side next to the surgeon handing them the instruments. You've seen that, they slap them in their hand. They actually don't slap them in their hand, but handing them all the pieces that they need and are supposed to be keeping track of everything that's used, including the sponges to soak your blood up. You don't want those left inside of you, so they count how many go in, how many come out. But that's not an implant intentionally. So this whole situation that's going on, so you've got a scrub tech and a surgeon and a rep, sales rep, and you've got a circulating nurse, and then sometimes you have a radiologist in there, and sometimes you have we actually had a neurologist, then you have the anesthesiologist, and then you have a patient. So they're in the room. All this activity is going on. They're trying to get this done as fast as possible. This particular surgeon on Friday really, really, really likes rap. He's a young guy. So we have rap playing in the background. And it is loud, because he's like in his zone. He's like cutting, screwing, inserting things. And all this while, the person in the sterile zone next to them is trying to yell to the circulating nurse what's being used. Screw, blah, 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 size, whatever, 2 or 3 used. And the circulating nurse is over on a computer screen, a really ugly application, trying to fill in the manufacturer's number, the lot, the serial number, and the expiration date. So it's chaos. It is complete and utter chaos. And because these products haven't been bought ahead of time, because the sale is going on in the OR, there's no inventory or list of what's in there. I mean, the sales rep literally walks in, they call it trunk stock. He takes it out of his trunk, and he walks into the room with it. So, how do you record these things? This is the problem, okay? Well, I started out by interviewing people. The easiest way to figure out what I needed to do next was to walk around with nurses and ask them, what do you do? Show me what you do. And I use a structured interview protocol so that I ask everybody the same questions because I want to be able to compare apples to apples. So I ask them a question, and I do it in context. I was in scrubs too. Ask them questions. They show me. They walk me around, and they show me what they're talking about. Now I have a visual idea of what it is. I start to own this along with them. These responses get captured. I use audio tapes sometimes, or if I have a scribe, I scribe them. This is just like every other method you've heard talked about yesterday. And what I'm looking for is I'm looking for patterns and themes. I'm looking for, in these interviews, where to go next. What data can I not capture in the interview? And what are the themes that I'm hearing over and over and over again in these interviews? And I typically do 3 to 5 different locations because hospitals vary. Trauma One Center is completely different than a local regional hospital. And a university research hospital is completely different than Trauma One. So you have to have a variety of these things, these places, and they all have different technology and they all have different processes. So I'm looking for common themes across all of these. And here is a sales rep who's being interviewed in the hospital about inventory. So this gives you an idea of sort of when you ask the question, how do you know what you have at the hospital? This is maybe the kind of thing that you hear.
So, I mean, the hospital comes to us and says, you're supposed to have 70 screws of this size. We have 150.
Oh.
So we can account for the 70 that belong to them.
Okay.
So, I mean, it kind of works that way in the fact that we keep a lot of extra stuff here. So, you know, we're never short. I mean, there's been instances where we've been a couple short, and maybe they didn't get billed for it. Maybe the wrong size got wrote down on the implant record, and they ordered back the wrong thing.
Okay.
And if that's done in December and we count in March,
Yeah.
you don't know when that happens. So,
Okay.
but yeah, it's a manual process of counting.
Cool.
So seeing this interview is a whole lot different than just reading a transcript, right? First of all, he's got his cell phone in his hand. He's in scrubs, and he's got a mask. He's going back into the room. He's got his cell phone. He's literally taking pictures of stuff and sending it to his office while he's in the operating room. This is important to know. It's also important that he felt comfortable in this environment to talk about, we don't really know what's going on. Sometimes the wrong thing gets written down. Sometimes we don't have the right stuff in the room. They're never going to tell you that if you take them off into a conference room somewhere and grill them. So being in their space where they're comfortable, being in context, you get a lot richer information from people. So going to a hospital also, like Friday, I arrived and I had permission basically to talk to whoever I wanted to. So I'll just find somebody with some time. People love to talk about what they do. They love to show you what they do. They love to complain and brag, and all of that stuff is valuable. So by engaging with them and asking them 4 or 5 simple questions, I got a complete tour of the hospital. I saw ORs before they were set up, after they were set up, when they were being taken down, and then I got invited into the OR to watch the surgery for 3.5 hours. So some of these things are kind of hard to plan ahead of time, because if you tell them, I want you to take me everywhere in the hospital and show me everything that you do, and I want to ask you all these questions, and I'd really like to observe a surgery, they'll just tell you to absolutely go away, because you sound intrusive and obnoxious. But if you say, I want to come find out the problems that you're having, how you solve your problems day to day in this particular area. Oh, now come on in, we want to talk to you. So a lot of it is how you communicate what it is that you're doing. And so these scripted interviews are very, very, very important. What we typically hear about when people talk about ethnography is videos. And videos are very valuable, but so is still photography. These videos I'm about to show you are what I call passive observations. So I'm literally standing off to the side, watching what's happening. I'm not asking questions. I'm letting all the behaviors in the room unfold in a very natural way. This, by the way, is the rep's room where they store all of these very expensive things in these trays. These are called trays. And they quite literally just throw them in there. It's a little bit frightening. Now, what I'm about to show you is, this is a hip surgery. The player on the right is the circulating nurse. So she's in charge of recording everything that clinically that's going on in the room. That's her job. The person next to her is the sales rep. The patient's on the left. The person with the hood that you can see is the scrub tech. And the doctor is about to ask for a particular implant that happens to come in a box, in a pre-sterilized package box. The process that should happen, the one they would give you the diagram about, this is how it happens in our hospital, 100% of the time, never deviates from this, is that the surgeon would call it out, the CN, circulating nurse, would tell the rep would get the box, unpackage it, hand it to the circulating nurse, and the circulating nurse would deliver it to the scrub tech, and then it would be implanted in the patient. That's what's supposed to happen. I'm showing you this because I want you to pay attention to what happens in this room. And then whoever saw what I'm concerned about, raise your hand, let me know. Anybody see what I was pointing out? Okay. Why don't you go ahead?
It looks like some people don't wear gloves.
Well, yeah, that's true. How the back? Because they were on film. Yeah. But the intent was clear. And actually, to answer your question on the gloves, when you're on the non-sterile side of the room, you don't wear gloves. I didn't know that before I went into one of these rooms. So
I was thinking about him holding a cell phone earlier.
exactly. Now you know why people get sick when they go to the hospital. Anyhow, so that is exactly what I saw, which was the nurse sort of said, hey, we're on film. Because the rep is not supposed to be handing it into the sterile zone. He's a salesperson. He has an MBA. He's not a clinical person. He's the sales guy, right? So when they tell you, I'm only saying this because, you know, he hands it to them, she hands it to them, really doesn't matter at the end of the day. But when someone tells you this is our process, it's always done this way. We have to comply with HIPAA compliance, and we have all these regulations, and we train all of our people, and blah, 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 blah. It's not always true. So by going in and doing these passive observations, and by the way, an hour later, they were doing whatever they wanted to do because they forgot I was standing in the corner. But you see all kinds of behaviors that are real. So when you're designing a solution to a problem, you need to understand what the true problem is and how people are actually behaving. Now, the implants that he was passing off to the circulating nurse are called sterilized implants. They come in boxes. They have barcodes on them. The barcode stickers, they can affix to manual paper records, which I'll show you in a little bit. These are pretty easy to keep track of because there's like 3, 4, 5 boxes, and they all have stickers, they have barcodes, and it's all very neat and tidy and organized. Most of the implants that go into people are not in those boxes. They are in what they call pans or trays, and this is a spinal surgery from last Friday, and those are all the pans and trays that might be used during the surgery. In those pans and trays are a combination of hospital-owned and managed instruments and implants, which are actually the lower right there in that sort of see-through pan, and then there's a couple black trays over on the left-hand side there. Everything else in that room was brought in by the rep the night before. They drop it off in what's called this SPD, the sterilization production area, where they get checked in. The rep tells them what it is, what surgery it's for. They put a little sticker on the end of the pan. They send that pan through sterilization. It's like 700 plus degree water. It's a lot of heat anyhow. And it comes out the other side. It's wrapped in brown and blue paper. And they put the sticker on the outside of the paper. And then it comes in a cart to outside the OR, just outside the OR, and I'll show you that also. And the nurse, before the surgery, will bring all these pans into the room and unwrap them and put them in a particular way up on this table for the surgeon and the scrub tech to pull from. None of those parts have manufacturer's numbers on them, slot the serial number, or expiration dates, because they all were taken off when they put them in the tray. So what do you do with that? And some of these screws are itsy-bitsy. An aortic clamp is like the tiniest little darn thing you've ever seen. I wonder how many of those get left in a patient. But anyhow, they have these little itsy-bitsy things, and they have them sterilized. So there's no way you can write the serial number. You know, we see in movies where they like take a pin out of a guy's leg and they identify him when he's dead because he's like got a serial number on it. That almost never happens. Most of these parts are way too small for that. You can't write on a screw. It has, you know, there's no way to write on a screw. One of the companies, Meditech, thought they figured it all out. It was Meditech. And they put these little tabs on them that you can break off, and it has the information on the little tag. Imagine if that little tag, like, fell in the patient. So, sometimes these brilliant ideas that are hatched in the conference room instead of in the OR. And actually, the nurses said they cut them on their gloves. They cut through the gloves because when you break it off, it's ragged. And they didn't even know there were numbers on them, so they throw them out. So, this is the kind of non-research-based thing that some companies might do. So, this is a typical kind of a situation where everything that guy in front is handing to the surgeon behind him is called out. And it's called out like a cannulated, 5mm screw with a blah, 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 blah. And the person on the other side in the non-gloved area is over here catching that information in the middle of heavy metal being played. So, it's not a communication that happens easily. And understanding what that is and the solutions that might be brought to bear is really important. And by the way, I haven't figured that problem out yet. This is my current research project. So, the last bit of ethnography, and this is very seldom talked about, is really artifacts and documents. So when I say an artifact, it's something that is in the environment that you can only find out about if you observe the environment. How many of you have Post-it notes stuck on your monitors at work? That's an artifact. How many of you have binders and reference materials that you use when you do your job? Oh. How many of you have cheat sheets on your computers that you use in order to get things done? Those are all artifacts. So knowing what those artifacts are really helps you understand how people have tried to solve the problems themselves. And it's important to understand and gather those things. So examples get collected. In this particular case with healthcare, a lot of these artifacts are actually paper-based. So I just ask them to make a copy of all the paper, and they do. They give me volumes of these things. And I have them explain what each one of them is for. And now I have a better understanding of their process. I ask them to show them to me used, okay? Because somebody can put a form together. Nobody ever follows any of the things on the form, right? They just use it as a piece of paper to stick things on. So I want to see what it looks like after you stuck all the stuff on it and see what actually got recorded. So those are the kinds of things that I collect. And they're very good about giving them to me, actually. What I'm doing here is I'm comparing those samples across multiple hospitals. And I'm also looking at what's the delta between real life, and intended use. So the person who put the form together had a particular use in mind. How the person used it is real life. What's that delta? And how do I deal with that as well? I don't have any videos of documents, so. But the other types of artifacts that you would see is here's a circulating nurse recording in the computer. Systems that they use are also an artifact. So they're using systems now. What kind of system is it? What do they enter into it? I quite literally take screen captures with a phone of the system that they're using and talk to them about what fields they actually fill out and how they enter the data. You can see these stickers in front of her. Most of them have barcodes on them. They have no way to actually enter a barcode into the system that they're using, not because you can't buy one of those little devices and not because you can't plug it into your USB on the side of the computer. The system that they're using doesn't accept barcodes. So this multi-million-dollar system is not barcode compatible. And oh, by the way, does anybody know there's like 3 different kinds of barcodes? So is it a complex barcode? Is it a 3D barcode? Is it a primary, secondary barcode? So understanding all of those issues, you find out when you're in the field. When I talked about the pans and trays, this is something I just found out Friday. All the pans and trays have a barcode on them, and they have a description as to what the pan and tray is. If they had a barcode reader and they had some idea of what the inventory was in each one of those, all they would need to do is just scan them, and it would record exactly what went in the room, and they could look at what came out, right? Seems simple enough. There's no barcode reader. So they take all the stickers, and they put them on a piece of paper, and they just send that off, and they file it away so they're compliant, Nobody uses any of the information at all. So, fascinating. So then what do you do with all this information? You gather all of this data. A lot of it's in your head, some of it's in notes, some of it's in videotapes. What I do first is I map what did I see? What did I experience? What's going on? Who are the players? What are the environments? Who's talking to who? How are they moving? Who's interacting with whom and why? So this is just an example. It's an eye chart. I don't expect anybody to try to read this, but this is trunk stock workflow. This is just the stuff that comes out of the rep's trunk from the time it arrives at the hospital, well, actually even outside of that, how the rep gets it to begin with, all the way through how it's used, and then sent back out of the hospital again. So by creating these diagrams, these are not typical process flow diagrams. These are like illustrative. Actually, your clients think these are like really illustrative and cool. But what you can do with these is you can sit down with them and you can circle and play with the paper and say, these are the areas we think we have opportunity and that we can impact. And the rest of this is noise. Just leave it alone. This is the only place we can affect any change. The other thing that can happen, and this is not a healthcare project, but this one, they had a whole bunch of projects on the roadmap. Anybody deal with big clients that have big lists of to-do things? Yeah. And they don't know how to prioritize them because they're like, and then somebody goes, infrastructure, and they go, infrastructure. And that's what you do for the next year. You put $20 million into infrastructure, and you hope at the end of the year that, things are better, right? Right? So this client, we did all of the ethnography that I just described. It was actually eBay for help. We did it with members. We did it with people who were in the help organization. They had all these different projects. We discovered all these themes, or I should say we all discovered together these themes. We prioritized the themes, and then we came up with a relevancy together, again, client, me, to each one of these projects. Now, they were ready to spend a bundle on infrastructure. That was their number one project. If you look at this and the relevancy to their themes, okay. Relevancy to their themes, governance and knowledge management were their two top projects, or should have been. And the last one here is just to show you another diagram, which is a current state and an ideal state. So this is starting to move into what could it be, using a vocabulary of visual communication. Okay, that's it. And just say, my company is called Curiosita. It's Da Vinci's first principle, and it's all about a desire to know and learn and grow. So, and it's a real word, so I'm excited about that. And if you need to get a hold of me, I will provide this presentation, and my email and company website is available through this. Thank you.